I'm going to briefly introduce myself and then my colleague, Dr. Allan Frankel. So I'm a surgeon and I am at Harvard Med School, and I do a lot of work now with the Center for Medical Simulation in terms of teaching and training. My disclosure is that I do a lot of work nationally and internationally to help healthcare organizations develop and sustain well-being programs, working around organizational change and very specific programmatic initiatives. And I just want to acknowledge my privilege and fallibility. I think we all come with, from different backgrounds, and I want to just say at the outset that, I think that it's always important to just acknowledge where you come from, and that you see the world in a certain lens, and it's a biased lens, which isn't necessarily a bad thing, but I just wanted to call that out. Then I have such a pleasure of introducing my friend and colleague, Dr. Allan Frankel. So he's co-founder and CEO of a wonderful organization called Safe and Reliable Healthcare. And he's also senior faculty for the Institute for Healthcare Improvement and Intermountain Advanced Training Program. So on a professional level, Allan is literally a world's expert on high reliability care, and specifically with a lens around leadership and culture. So he was such a natural person for me to ask to join us today. And then on a personal level, Allan and I have worked together for a really long time. We met each other around educational efforts at Mass General Brigham years ago, and have stayed in touch and collaborated together. And I can just tell you, it's just always a pleasure to work with him for just so many reasons. One of which is that he really does walk the talk around acknowledging fallibility and being collaborative, and really keeping the focus on learning and improvement, regardless of what he's doing, including anything we're working on together. So we will model this for you. And I wanted to say that because the way Allan and I interact, we hope it's exactly what we're trying to say is important, which is that we both of our commitment is to getting this right as right as possible, including being with you here today. And so we, for that, will cross monitor. He might say, Joe, I think we need to get back on track, or let me just interrupt here, or redirect, and I might do the same. And we do this because we have an incredible amount of trust and psychological safety in our working relationship that we've had over the years. So if you see that, that's a good thing. That's how we roll. So I just invite you all, kind of privately, to think of a time when you were at work, really working hard and, very challenging healthcare setting. And you felt really supported by the people around you, your teammates, the organization that you work in, and just to reflect on how great that feels, even if the work is really, really challenging, right? To know that you have people around you who are supporting you to do the work, and keeping, when it comes to clinical care, keeping the patient at the center of the work, and that you're all supported to do that, and supporting each other to do that. And I just wanted to have you picture that, because we've all experienced it, and that's what we're going for, right? That kind of working environment. And I think, though, in order to get more of that working environment, we have to really take a long, hard look at what threatens that kind of culture. And so I sort of call it the dark side. And I'll give you just two cases, if you will, to keep in mind here. So one is Dr. Dismissive, who's an interventional cardiologist, and they can be demeaning and hostile to various team members, sort of, chastising the team for not moving the cases along fast enough, dismissive of clinical concerns, refuses to discuss operative plans, blames others when things are going wrong, and then uses demeaning tone and content, saying things like, well, you're all just on the clock. I'm the one who really is dedicated to patient care. You all just have set hours and you'll be leaving. And it just shows you don't really care as much about the patient as I do. So, this isn't exactly a specific case, but it comes from an amalgamation of cases that I had the opportunity to assess when I was at Brigham and Women's Hospital, where I directed for 10 years a Center for Professionalism and Peer Support, where any concern about any physician, whether it's intern through senior faculty at the organization, would come through me, and I would assess the concerns and then work with their supervising physician on giving feedback and then setting a structure for that person to improve their pattern of behavior. So this is not an unusual kind of example. So I'll give you another one. I call it punishment central. There's been an adverse event, and you're called by the organization to justify your actions. You try to explain the reasoning for your choices at the time, which at that time were in your opinion, seemed to be the right choices. Only in retrospect, they didn't work out that well. But the focus of the event analysis and people around you has been really just on the bad outcome rather than how did that happen, and definitely not about, let's learn from this and let's prevent it from happening in the future. So you're feeling isolated and demoralized, and you're actually even fearful that this might affect your career, your job, what have you. So those are two cases which clearly threaten that kind of culture, that workplace culture that I outlined when I had you image. So it's our belief that psychological safety, having a culture of psychological safety, is absolutely foundational to CRPs. That, I'd go so far as to say you really cannot have an effective CRP if there is not psychological safety. And so we're going to talk to you about what that means, and so various manifestations of both psychological safety and the lack thereof, and how that affects, at the end of the day, patient safety, but also just a process where we're trying to be transparent and compassionate and have a learning and growth mindset. So let's talk about culture first overall, because you all hear this a lot. We say culture this and culture that. And I think Allan and I would, oh, maybe somebody could, if you can all mute, that would be great. Thank you. So, culture is not like a separate little thing, a little piece of the pie. It underpins everything we do. And I love this definition from a colleague of mine. He calls it patterns of relating that persist and change through ongoing interaction. So it's not this ethereal thing. It's actually, culture is manifest in how we relate, processes and behaviors that we, the patterns of which we are exhibiting on an ongoing basis, or deciding if we want to change the culture and then change those behaviors. So again, it's definable, and the beauty of culture is it's never written down, right? I mean, if you think about it, you've never been in an organization where there's a cultural manual. You've got a mission statement, you have bylaws, you've got policies and procedures, but culture is not written down. And the beauty of it is that you don't need to change your mission statement or your policies and procedures. In fact, changing them won't do anything to culture. You can say, there are things in our culture that need to stop, and we're going to stop them, or we're doing so many of these things well, let's do more of them. So culture is very malleable, not written in stone, not written at all, as a matter of fact. So let's talk about a culture of psychological safety. So Amy Edmondson's done work around team psychological safety, which is a shared belief in interpersonal safety within the team. And she says it has that you have the sense of confidence that the team will not embarrass, reject, or punish someone for speaking up. So this is an aspect of team psychological safety. And it stems from mutual respect and trust among team members. That's a big deal, right? To have that mutual respect and trust. As I was saying in the beginning, I have that with Allan. And so, we have that mutual respect and trust so that we can really learn and grow together, which is what we're thinking about for entire organizations. So this is the team psychological safety definition. And here I'm actually, it's not advancing, hold tight. So this is actually comes from a piece that Allan and his colleague Mike Leonard wrote about safety culture, where what the core of safety culture is having people in the organization having a learning and growth mindset, where people feel safe talking about errors. We don't punish for human error, and find and fix vulnerabilities in our systems and our behaviors. And I want to say one brief thing about this. Some people think that a safety culture means you just look at systems, right? There's no personal accountability, but actually not at all. It's both personal accountability and systems accountability, but with the idea of improvement rather than either getting beat up or beating up on oneself. So I want to turn it over to you, Allan, to talk about a high reliability culture. Whereas, as I've said, you're a world expert in this, and if you could just talk about what that means.
Hi, Joe. Yeah, I'm not happy to do so. I guess there are a couple of thoughts that I'm having as you're beginning to kind of delve into the conversation and the description. But maybe what I'll do first is just spend a minute and talk about high reliability and the way we are beginning to think about it. For those of us that are actually going into organizations and running interventions, where people are coming in and saying, and Allan, can you and your group come in and help us create a high reliability culture? And then the question is, well, what are we talking about? What does it actually mean? And so on this slide, I've made two statements that I think get at the heart of what high reliability actually entails. The first one is actually an engineering definition of reliability. The classic phrase is failure-free operation over time, stable over time. So failure-free obviously has a reliability component to it. And the fact that you can do that over a period of time suggests that you have a stable environment in which you're able to achieve some level of operational excellence. So when engineers talk about reliability, this is what they're referring to, and it may be the production of light bulbs coming out of a machine that makes the light bulbs, and how failure-free are the light bulbs as you produce them. For us, obviously, it's failure-free care of patients over time, consistently as patients come through the healthcare environment. Mindfulness, the term has a long history, because if you think about Cousins, Colleen Roberts, Wyke and Sutcliffe, in their book Managing the Unexpected, which really kind of made mindfulness a common term. Mindfulness pertains to a particular way of thinking, much of which Joe has now referred to, but has some detail. And Wyke and Sutcliffe kind of characterized mindfulness in their evaluation of organizations that were predominantly failure-free and stable over time. And the 5 components, preoccupation with failure, commitment to resilience, deference to expertise. There were these component pieces of a way of thinking that led you to a highly reliable environment. And if you add a lot of those mindful pieces together, they don't exist unless psychological safety is robust. So this boils back down to the degree in which psychological safety exists for you then to build the mindfulness in which you can then achieve failure-free operation over time. Thanks, Joe.
Thank you. And I want to point out something that Allan taught me a long time ago, which is that failure-free in medicine doesn't mean error-free, because we're human and we're wired to make errors. The idea is making sure those errors don't reach patients. And so some people, I think, confuse that. And I think it's important for us to remember that we're human and we will make errors, but we don't want them to harm anyone. So I'm going to unpack a little bit more of some of the components. One is professionalism, which there's lots of definitions of it, but I just decided to define it when I started this center when I was at Brigham and Women's Hospital. And essentially, I use the definition of behaviors and processes that support relational trust. So we know, but there's lots of studies showing that we have a fair amount of unprofessional behavior. These are just some of the studies. There's many more. As I said, we're going to have to look at the dark side before we can really build a system that is the way that we want it to be. So teamwork is another aspect. And there's a study showing that patients whose surgical teams exhibited less teamwork behaviors were at higher risk, patients were higher at risk for death and complications. So, okay, this is not something that when I was training, which I'll admit was a long time ago, but really even until the last like 15 years, that people really even knew. We thought that patient outcomes were totally dependent on technical and cognitive skill. And nobody really knew how much the actual outcomes for patients were dependent on how we communicate with each other. And so obviously relational trust comes in here as a really big factor. So because of this, the Joint Commission came out in 2008 with a mandate saying that all of the healthcare organizations that they accredit need to end intimidating and disruptive behavior among everybody in the healthcare organization, right? And then further define these are behaviors that undermine a culture of safety. So they were particularly focused on disruptive behaviors, but there's others, discrimination, those sorts of things. They are also undermining a culture of safety. So, one thing I always want to, whenever you see good people, which pretty much in my world, and I think in your world as well, people really want to do the right thing. And you see us, you see us failing, I think you have to think of, well, why? There are reasons why we're not bad people. So what the heck, why in medicine have we tolerated unprofessional, untrustworthy behavior for so long? And these are just some of the reasons. One is that sometimes people exhibiting those behaviors make a lot of money for the organization. Now, the problem with that rationale is, yes, they make money in some ways, but they lose you more money than they actually make you because of retention, morale, productivity. Never mind that, but also they are risk to patient safety. We're afraid. A lot of times we're afraid of holding people accountable, that they'll sue us or they'll retaliate in some way. And we're not trained to have difficult conversations. We justify it by saying, well, that's the way I was trained and that's the way it used to be. And it seemed to work out fine, which isn't true, but that's what we think. There's sort of a myth of pedagogic rationale that, if you're humiliating people, they'll learn better, which is just the opposite, as it turns out. I think a lot of people who exhibit these behaviors don't really at all see the effect they have on others. And nor do we sometimes. We can all have blind spots as to how we're affecting others. And then cultural relativism, well, so-and-so's from a different culture, and therefore that's acceptable, which is, it helps explain why someone might behave in a certain way. But you see, we're in our own culture and we need to say, these are our standards. So these are, I think, some of the reasons we haven't held people accountable, and we need to start doing so. Event analysis is huge when you think about psychological safety, and certainly when you think about CRPs. Really, the core function initially of a CRP to start with is understanding what happened. Now, of course, it's communicating with the patient and family about what happened, but it's really getting an understanding of what happened. So the way that's done is really, really dependent on how the organization views themselves and views setting a safety culture. That said, we know, and there's a lot of data on this, that being involved in an adverse event, particularly where there's an error, has some significant negative fallout emotionally for the healthcare providers involved in that error. Sadness, shame. Shame is a big one. That's where you go from saying, I feel bad that happened, to I feel bad that happened, and it happened because I'm not good enough. I'm a bad nurse. I'm a bad doctor. I'm just not worthy. And there was a study by Helmreich who I thought really explained this well, where he looked at aviation and medicine and found that both stress the need for perfection and a deep perception of personal invulnerability. In other words, to keep patients free of harm, we're supposed to expect perfect performance, error-free performance for ourselves and others at all times, which as I mentioned, is unfortunately impossible. The harm part isn't impossible, but making no errors is impossible. But I don't think we've internalized this. So then you do make an error and it really, really rocks you in such a big way. And then I think there's fear. We're afraid of, in that case I gave, like, how is this going to be handled? How is the event going to be analyzed? What are the repercussions going to be? Is it going to be done with a learning mindset and growth, or is it going to be something punitive? And I just wondered, did any of you send the memo out to your organizations that said you're done with shame and blame? Like, we're done. We used to do that. And, of course you didn't. Nobody got a memo saying we're done with shame and blame. We might have sent a memo saying we're doing just culture, but remember that we've been mired in a shame and blame culture forever. And getting away from a culture like that, it requires seeing where we still do shame and blame. So I think if you look at various processes, you'll see that there are times when a process could be done in a shame and blame way, but it could also be done in a just culture way. So look at event analysis of any sort, M&M, root cause, collaborative case review. Again, could be done either way. Being reported, an event reported to the Department of Public Health, to being reported to the Board of Registration of Medicine. In the Netherlands, it's the Inspectorate. In the UK, it's the Royal College, Court of Law, media. These are all things. These are all processes that are reactive to adverse events, and they can end up being very punitive. Not all of them, of course, but I want you to be able to see, like, there are times when we are undermining what we're saying that we want to have. And so, rhetorically, I'm going to ask, like, all those emotions that I talked about, fear and shame and anger that the system isn't supportive and isolation, do you think these might affect our discussions with patients and families? How could they not? If you're emotionally worked up and impaired in some way after something happens, which, if you're a caring, compassionate clinician, you're going to feel pretty horrible when you've been involved in inadvertently harming a patient. And so telling people to just be compassionate and be transparent without supporting them in doing that is probably not going to work. I just want to come back as we move forward here, just to how psychological safety it would impact the sustainability of a CRP. So one is, if you have psychological safety, people would be very interested in and confident about reporting errors, their own and others, because they know that there wouldn't be punishment. It doesn't mean there's no accountability, but it wouldn't be a punitive kind of reaction, obviously, unless you do something, really risky, or just, let's say, out of the bounds of what's okay to do. And so, if you have a system, you have a process where people know that they're not going to be treated fairly when they report errors, then they stop reporting, or they don't even start reporting. And so right there, and if you're not reporting an error, of course, you can't do CRP. You can't, you're burying it, you're hiding it. Speaking up, being able to say to somebody, hey, I'm worried about this. I know you're choosing this approach, but I'm just concerned. And psychological safety is what would give people, with the right context, the confidence that they could ask a question, or maybe give me, as a more senior person, some information that I might not have, because they feel they won't be humiliated, embarrassed, or just made to feel wrong. And as I mentioned, psychological safety would translate into transparent and compassionate conversations with patients and families. Like I said, you can't give what you don't have. And if you're just incredibly ashamed and terrified, it's going to be harder to really be present for the people who really need you, which are the patients and families. And then, and this is where, Allan is just such an expert, but the whole idea of having an organizational mindset that's geared towards learning. I mean, can you imagine, and Allan's work is all around this, is being in an organization where, when something goes wrong, the immediate thought is, gosh, how can we learn from this? How can we do better? Rather than who can we punish? So I think all of these are absolutely domains where they depend on psychological safety. Allan, did you want to add anything to this part of it?
Yeah, as I'm listening to you talk, the thought that's striking me is this concept of what's proactive and what's reactive. To some extent, if I'm being simple-minded, a communication and resolutions program by definition is reactive because it's reacting to some event that occurred that now needs to be mitigated or in some way managed. Where psychological safety comes in, and you referred to it, is that psychological safety moves over and looks predominantly, not completely, because obviously in the communication and resolution, psych safety is a big piece, but the goal here is to have less events for which you need a communication and resolution program. So psych safety is all about being proactive and creating that environment where you are speaking up about the near misses before they become the events, as a way of making the system continuously safer. Again, safer and stable over time. So the heading of the slide kind of delineates in a simple way the reactive versus proactive aspects of what we're talking about.
Great. Yep, that's a very important point. Thank you. The next component that I just wanted you to just talk a little bit about, Allan, is what role leadership plays in creating sustaining psychological safety.
Yeah. So Joe, I put this slide in here when you asked me to kind of talk about this, because the framework that you see in the center is essentially the true north. It's the framework for high reliability that we now use in both evaluating organizations and then going in and running programs to intervene to help organizations get better. It has a lot of similarity to what you see coming out of the Joint Commission, the oral work that was produced there, and from the Lucian Leap Foundation when Lucian was running it, and the National Patient Safety Foundation over the years, and when Tejal Gandhi was running that. The frameworks they developed have similarity to this. I put it up here because when we look at organizations, we are thinking of them as having four major organ systems. There's obviously the culture and the cultural attributes, much of which Joe has talked about, but individuals and personal accountability, how teams function, the degree to which just culture and professionalism surrounds those individuals. That foundationally then gets you into this process of gaining knowledge, the reporting of near misses and events, for example, from which you can learn, and in learning, improve, and then ultimately implement those improvements sustainably over time. And that's the learning system that we kind of generically talk about. The interesting piece about leadership is that if you have a title that indicates that you are a leader, manager, director, chair, chief, or otherwise, you fall into this category of individuals whose responsibility it is to create the culture, collect the knowledge, and maintain the learning process that needs to exist in your organization. And what we've done in the last couple of years is to look at leadership and divide the attributes of leadership into three groupings: the skills necessary to pull the levers on culture, knowledge, and learning; the calendared activities that leaders perform that you can see on their calendars that support that effort; and the behaviors they manifest as they go around and participate in these activities. When you boil it down, the first one, skills, is literally a set of lifelong learning activities around the details and the nuances of professionalism, respect, just culture, human factors, improvement methodologies, leadership management styles. All of those are, white papers and books that leaders have to begin reading. They then manifest those in activities. The VA put 4 in place. They wanted safety forums, leadership rounding, visual management, and huddles as leadership activities in the 174 medical centers in the VA. And then the behavior that people have to manifest are the behaviors, many of which Joe described: professionalism, respect, humility, curiosity. And so when you become a leader in an environment that you want to be highly reliable, you're embarking on a journey in these three components of the framework that is lifelong and essential to achieve a learning system on which you can place a communication and resolutions program that's going to be effective. I'll give it back to you, Joe.
Thank you so much. That's lovely. So I'm going to talk a little bit about building a program. And, there's lots of programs to build, but I'm not going to talk about building CRP because that's a huge topic and a lot of expertise around that, and many webinars that have come before this and will follow. But I'm going to talk about building an example of building a program directed towards improving psychological safety, one of which would be the program around professionalism initiative, just as an example of what I think the components are for establishing a program that has psychological safety. So, the first thing is you have to get the commitment of leadership, to Allan's point. You really can't just do this from the ground up. The leaders have to understand it, have those knowledge and skills and really manifest them in all that they do. And so, I call it making the cases. I think leaders need to see that this matters. And I can't stress to you enough the fact that many of us, as senior leaders, we didn't have this knowledge about how those behaviors and how safety culture and psychological safety actually mattered. So we were overemphasizing technical and cognitive skills and underemphasizing these probably more important drivers of the outcomes that we want, which is safe patient care. So you got to get your leadership committed. And like I said, I'm going to talk about specifically professionalism program. And I have a bias, like I identify as a surgical educator, I think you have to help people. I think just going around and telling people don't do this and do that just doesn't work. But if people get educated in skills and also in reasoning why this matters and how they can deal with things like conflict in the workplace, microaggressions, like how do you respond to those things that might undermine psychological safety? How do you actually handle them? And so I think an educational program is key. What we used at the Brigham around this professionalism was we did, required training for healthcare providers on how to prevent harassment and disrupt the behavior. And we urged everyone to think of themselves as potential victim or target, but also perpetrator. I mean, if you put me in a under-resourced environment or, I'm tired and I've got production pressure, it's hard to maintain my level of respectful professional behavior, but it is my job to do so. And then bystander. And it turns out that if you look at the bullying literature, bystanders have a tremendous amount of power. Some people call this upstander training, but the data indicates that bystander training is extremely important. And I love this. It's from a book on trauma and recovery, that it's tempting to take the side of the perpetrator. All the perpetrator asks is that the bystander do nothing, whereas the victim asks the bystander to share the burden of pain. So I think people need to be trained on how to do this. And we did do that training. This comes from the Academy of Communication and Healthcare, that not saying something, not speaking up, or not reporting if you're not safe to speak up is not just neutral. It's basically telling people you're fine with what they've done. So my colleagues at Center for Medical Simulation and I developed an algorithm for speaking up, for managing conflict, for giving difficult feedback that is grounded in really wanting to understand the person's perspective, the person to whom you are giving the feedback or managing conflict with. And I put this slide up because, well, medicine is very hierarchical, right? And it's not, hierarchy is not bad. It really isn't. It tells you what your role is, who's in charge. We have it in the military, we have it in medicine, and being a senior person, I'm a huge fan now of hierarchy. So I'm up at the top, towards the top of the ladder. But this is not the same as a hierarchy of respect. And whether you're cleaning the floors or in the operating room or wherever, or you're the surgeon in charge or, the ICU director, everybody you're working with is entitled to the same degree of respect. That said, speaking up and giving feedback has to honor the hierarchy. And so we're not asking people to speak up to somebody they think could threaten them, but we are requiring or asking people to at least report it. So I just want to be clear about that. You got to be realistic about what's fair to ask. In parallel, if you go around telling everybody, here's our new rules, because, let's face it, our cultural norms change, right? And they have very much changed since back in the day when I trained. So you need to tell people these are the new expectations. It's not okay to make jokes about X, Y, or Z, even though it used to be, or it probably wasn't ever okay, but we accepted it as okay. So education and give them skills to manage this. If you go around doing that, but everyone knows that you're letting the high rollers, behave in a way that undermines, like Dr. Dismissive, blaming others when things go wrong, then people will get very cynical very quickly. So you have to have in parallel an accountability program. And this is really challenging for healthcare organizations. It's absolutely doable. We did it at the Brigham. We have really good results that we publish, but you have to be very mindful of how you do it. And this is my view of the components of accountability program, that you need a safe relational environment for raising concerns, where it enables giving feedback to the person about whom concerns are raised, rather than an immediate pivot to punishment. So the idea is give people the opportunity to change and to learn and to grow. It should protect the people reporting concerns, and also be fair to the individuals about whom concerns are reported, because they're not all valid. You have to really assess them. And I don't think we should be relying on, online safety reporting systems for this. I actually co-authored an article about why we think this is not the best way to really move forward after there's been interpersonal conflict. So I want to be clear, and we're winding down here because we want to make sure we have time for questions, comments, affirmations, or pushback. We're not talking about expecting people to be perfect, right? No one's perfect, and if I roll my eyes once a year, like, I hope you forgive me, I'll forgive you. But when it's a pattern of behavior, that's where the organization needs to take a stand and say it's not okay. Because even if you're not throwing things at people, which used to be okay, by the way, back in the day, just being sarcastic and rolling your eyes, sighing, that actually will put a damper on people being willing, will put a damper on people's sense of safety. They don't want to be humiliated, and those behaviors are humiliating. So we're talking about patterns of behavior, or of course, single incident egregious. And then you can't just give feedback and opportunity to remediate. You have to say, we do expect changes. And if you don't change your behavior, then, you escalate accountability. And this is adapted from Hickson's work. So, as I said, this was an example of, one program getting at psychological safety, the professionalism program. I think leadership training is key, and, Allan's a real expert in that. Two other programs I just want to mention, which I believe will support psychological safety, would be peer support and communication coaching. So we did a study where we surveyed, this was a physician study, but where we surveyed physicians about different emotional stressors. And this particular graph was an answer to a question about errors. If you were involved in medical error, where would you want to get support from? And 88% wanted to be supported by a physician colleague, even though we had great employee assistance program and mental health professionals, that people want to talk to their colleagues where there's this occupational stressor. So I believe, you have to organize programs around what you know people actually want. And so we did start peer support, and I've helped dozens of healthcare organizations across this country and others start peer support programs. It's not the only way forward. I would never say that. It's a way forward, and it doesn't cure everything. But I believe, if we're not there for each other at these incredibly stressful times, then I think, honestly, this is in the candor, right? Toolkit is you have to support your healthcare providers, because how else are they going to show up for patients and families? You saw some of the emotions that we have a lot of data on. And so we need support to be able to to be transparent and compassionate. Otherwise, I think you're asking people to do something that just isn't possible. Same thing with communication coaching. It's a very, very challenging moment for patients and families. And also for the healthcare providers who, none of us has a lot of experience in, having these conversations, because fortunately we don't have these often in our career, but it will happen occasionally. And we need to know how to be there for patients and families, and having these conversations with a disclosure coach who can actually, or communications coach who can help you prepare for the conversation can be really, really helpful. And I did actually have that role at the Brigham, and I found it really rewarding. And got good feedback from the people I helped prepare. Allan, did you want to talk about this slide before we open it up for questions?
Yeah, the reason I put this up, Joe, is because I had opportunity to climb down into the USS North Dakota, which is a nuclear submarine. I was invited to come down and take a look at it. And what struck me is that I climbed down into this thing. You imagine, it's got a nuclear power plant. The nuclear power plant is linked to a desalination plant to get water into the system. That's linked to a device that separates hydrogen and oxygen, so you can get oxygen into the submarine. And all of that is sitting on top of ordnance that kind of can blow up entire cities. And I spent 2.5 hours with the captain of the nuclear submarine. And rather than talking about the physics of all of those components, of which I was seriously interested, we spent 2.5 hours talking about the culture of what it's like to be a leader in an environment where high reliability is essential. And we weren't talking about the technical pieces of what goes on in that nuclear submarine. We were talking about management, relationships, psychological safety, and hierarchy. So this is a picture of Rickover, who is the kind of, the grandfather of the nuclear submarine part of the Navy. And when he got called up to Congress and asked, how did you make the nuclear Navy so safe? His answer was, I'm always chagrined at the tendency of people to expect that I have a simple, easy gimmick that makes my program function. It's multifactorial. And so aside from the technical skills to deliver healthcare, the conversation by leadership about the topics that you've been talking about, Joe, are the ones that need to occur at a leadership level almost continuously, not almost, continuously, in order to get the kind of environments that we want, that are stable over time, where mindfulness is the main component, and where the communication and resolution programs then are really robust. So it just struck me as a kind of fitting appendix to your comments for today.
That's great. And I really appreciate the focus on the fact that, there's no single solution. And, as you've mentioned, it's this tireless focus, eyes on the prize, just over and over again. Can we learn? Can we improve? Can we make it safer? And is everything we're doing supporting that learning and growth mindset, and supporting psychological safety, so we can feel safe to learn and we don't hunker down and feel defensive and destroyed by what's happened. And I think, again, you can't send a memo, you have to practice it daily, if you will, and be clear and mindful with everybody. This is what we're doing. This is why. Kind of a relentless focus, I guess, is a phrase that I think you've used, and I resonate with. So I want to close before we open up for questions, and it doesn't have to be questions too. I just would I think we're both, Allan and I, interested in how does this sit with you? It's a big topic, right? we knew that when we were asked to do it, and I think it does affect so many parts of what we're thinking about for CRPs. But we'd love to hear what you think. I want to close our portion with this slide. It's a picture I took. So I did some professionalism work at a academic center in Australia, and my husband came with me, and we decided to go to Sydney. And of course, you're in Sydney, you have to see the Opera House. And there was a big outside of the Opera House, it was a big construction project on the steps in the plaza leading up to the Opera House. And there was a bulletin board for the construction team. And I went over and read it, and I took a picture. I think you'll see why. Our house rules: I will do everything I can to go home safe. Never forget rule number 1. Respect my workmates. Communicate positively with those around me. Challenge my mates to do the right thing. Present fit for duty and ready to do my best. Never take shortcuts at the expense of safety. Lead by example and be proud of my work. Speak up if I see something not quite right. Step up and help my workmates if I see they need help. So, you know what, that's who we are. And I've had such an incredible opportunity to work with so many people in so many different healthcare organizations. And one thing I want to say is I'm just blown away by the commitment of people to really make the system better and really focus on patients and families. And I also want to say, because I forgot to in the beginning, so I'm very involved with the collaborative, and I sit on the best practices committee. And one thing I love about the collaborative, and I can just tell you from experiencing being on the best practices committee, is how important the patient and family voices are. And I want to shout out to our best practice members who are patient and family advocates, just how important that is to keep patients and families at the center of everything we do. So I realized I forgot to do that. So thank you so much. As I said, let me come out of sharing, and we would love to hear, again, could be a question, but also what part of this resonates with you? What part are you like, I don't know, that doesn't seem realistic. What are your thoughts? Anybody really interested? And I think we have to do it probably by chat.
Yeah, or
Yes.
audio. Yeah.
Yeah, feel free to unmute as well if you'd
Oh,
like.
good, great.
Or, either one is fine. I really liked that you talked about how, the culture of safety and psychological safety, how that will impact how clinicians then communicate with patients and families, because that was something I was thinking about as well, how that sort of culture then, spreads out and impacts patients and families as well.
While people are thinking, so Kay, I'd love to read what you wrote, but I was going to say that, people talk about, processes, like you can have, a written process like CRP is, kind of an algorithm. This is what we do, but how it's done is the key. And I would like to give you an analogy. So there's the, as you all know, there's these surgical checklists, right? And there was a lot of data that came out that said, you can have one team that does the surgical checklist, but they're doing it in a way that is so counter to what it's supposed to do, that it's just worthless. Where other teams doing the same checklist, but they're doing it with we really care about this. We're really actually going to listen to each other, et cetera. And so it's how you, it's not really just what does your process look like on paper, but how do you actually manifest it? What are those behaviors that you manifest? Let's see. So, yeah.
So one of the questions, I don't know if Jay Cooper is Jeff Cooper, but if it is Jeff, hello. So we actually have some data on the impact that COVID has had. So, my company surveys about 1/5 of the hospitals in the US. So at any point in time, we have about 350,000 respondents in our benchmark. COVID has been really interesting in its impact on the cultural survey results in 2 ways. One is we are seeing in a variety of places, and I think it's going to be thematic, that the impact of COVID on nurses has been pretty bad, quite frankly. And if we look at the overall culture scores for nursing across most organizations, they've declined in double-digit percentages. Interestingly enough, the impact on physicians overall has actually gotten better. So physicians overall fared better over this last year. Now, obviously, that's all physicians, but you have to consider that there's a subset who are taking care of COVID patients in the hospital, and another whole group of physicians who are potentially at home or doing less clinical work. But physicians overall have done better than nursing has, as we look at the two main groups. The other piece that I'm seeing across the country in every conversation I have with leadership is that senior leadership in organizations are fried. That may indeed be many of you, but the tensions and the stress associated with the COVID period has made it very difficult for senior leaders. And then the other piece that everyone is talking about, just kind of seeing it in the literature, but we're hearing about it in the survey results as we're looking at the comments, is this whole issue of post-traumatic stress for a subset of the population. And I think that's clearly going to be true. And one of the questions is, what percentage of our nursing population are we going to lose as a result of the COVID, the COVID year and a half that we're into right now? I'll make one other comment and then I'll stop. Those organizations whose culture was improving before COVID came around, where we had serial culture survey results, continued to improve in general during the COVID period. A little more burnout, but teamwork, safety, leadership, local learning, all got better. And those organizations that were struggling with those domains and culture when the COVID period came by proceeded to decline during the COVID period and get worse. So the organizations that were thinking about things and making them better continue to manage to do so in the last year, which was also somewhat unexpected.
Excuse me, that's a really interesting observation. My experience around is more around trying to provide preventative emotional support for clinicians during COVID. I mean, I was doing that before COVID, but big pivot. And I will say that one of the things, and I co-authored an article with Tim McDonald. We wrote this up in the New England Journal, is many times programs to support emotional well-being are poorly utilized by different healthcare providers because of the structural and cultural barriers to saying I'm hurting. And so I think, I'm not sure I could immediately connect that to psychological safety, but I can certainly say if you are, emotionally incredibly stressed out and even impaired, if you will, and I don't mean substance use disorder, but I mean just wrung out, then it's really going to be hard to be present for your colleagues and for your patients and families. And so I do think it is all intertwined. And I think a lot of us experienced, seeing that we have to, I mean, this is, and I have a bias here, so I put that in disclosure, is using a proactive reach out peer model for reaching out to peers saying I just want to talk to you about what's been going on for you in the last couple of weeks or month or whatever. And let's talk, versus making people self-identify as struggling because we have this barrier of saying I'm hurting. We're not supposed to hurt. You signed up for this, right? And we're not supposed to be vulnerable. So I think there is that relationship, but I think that big perspective that Allan has is really interesting. Also, Jeff, thank you for your kind words. Somebody, Richard, I guess, talked about that is, that what we said resonates, but it seems so fragile, which is a great word. It's true, it is. And there's often inconsistent modeling by leaders or inconsistent application of accountability. And absolutely, I think, this is the challenge for healthcare organizations. Can you say that the expectations we have are for everybody, not just the vulnerable, right? Including people who you perceive as powerful and bringing in a lot of money. And it's doable. We have data to support that it's doable, but it really does take having a structure and a commitment from leaders that we actually are going to hold, even the high rollers to the same standards. And again, it's not a punitive sort of mindset. It's we'll give you a chance to remediate, but you also have to have escalating accountability. So I'll just tell you one of the things we found in the data we published when I was at the Brigham was that, of the several hundred physicians about whom concerns were reported, after a process of, attempted remediation and feedback and all, 11% actually left the hospital because of professionalism reasons. And so what does that say? It's not a proud statistic, but it says the hospital was willing at that time to say, we know, like, actually, you can't be here and continue to behave that way. So Beverly, great question, Bev. What do you do if your leadership doesn't act in ways that allow? I think it depends on your sense of safety. Can you speak up? And when I say speak up, it doesn't necessarily mean just calling someone out. And I know you would never do this, but telling them how unsafe what they did is. But having a conversation with somebody, Alan and I talked about modeling this kind of conversation, but that's probably a different webinar. Is how do you have these difficult conversations with people, especially if they're higher up on the hierarchy. But I might say something like, if I were having this, you're that leader, Beverly, and I, having that conversation with you, I might say, I want to talk to you about some things that I've noticed. And it's not, all of who you are, but it's really something that I think is problematic. And here are the specifics. I noticed that you, blame people, or I noticed that you raise your voice when you're frustrated, whatever the specific behaviors are. And then saying, I know you care about this organization. I know you care about the people in it and the patients. Can you help me understand why, what generates this kind of behavior? Because as it's kind of, it is undermining of the sense of, of learning and trust. And I'm sure you don't want that. So, it's really being able to sit down with somebody and say, here's what I've noticed. Here's why I'm concerned about it. Help me understand where you're coming from. Recognizing that most people don't see where, how it's impacting others. Or if you are in a position where you can't bring it forward because you don't have the safety, is having someone who does have the power to, or the stature, if you will, or the safety to be able to sit down with that leader and say, hey, let's talk about this, with the idea to improvement. So it's doable. I'm not saying it's easy, but I think if you don't do it, or if it isn't done by anybody, I think it's hard to really go around telling everybody we have this, these CRPs, this just culture, this psychological safety, because everybody's like, oh, really? I don't think you do. The leader's undermining it. But that's a really important question. Not an easy answer.
Joe, let me add another perspective to this. One of the actions we take when we're asked to come in and run interventions is to, the first thing I'm always asking is, let me look at your culture survey and engagement survey data. So, because engagement and culture surveys, and especially the comments out of them, are pretty insightful. And if you do them well, they really are representative of how people feel. So one of the ways in which we engage with leadership is to come back to them and say, look, let's just take a look at the way your organization perceives you. And there are other ways of doing it, because you can do 360 evaluations of managers and have them understand how their direct reports see them. But I can tell you that, we're in a major academic center right now in the US, ran a survey across, 30,000 some people, walked back into the leadership and said, look, your middle management is in trouble in terms of the way it's perceived by the frontline providers. And we're now heading in to begin to remediate that set of issues that they were looking at. So, Joe talked about a one-on-one conversations with leaders whose interest obviously is to get this right most of the time, often don't know how to do it. The other way is if you're talking about organizational leadership and the need to move them, measurement counts a lot. Because even the measurements we've got now, we can link to clinical processes and outcomes. We know that our culture survey data meshes to the CMS 5-star ratings, and that we can delineate between 4 and 5-star hospitals and 1, 2, and 3-star hospitals based on our culture data. We can predict where organizations are going to go. That's real money. Those are hard dollars that organizations are getting paid. So there's a variety of ways that you can get to leadership around the issue of psych safety in some of the measurement that you do in your organizations.
That's great. That's that's the more meta perspective. I love that. So thank you. Thanks, Allan, for being the colleague you are and showing up with me today. And thank you all for, like I said, taking time out from your days. And I want to thank Paulina and the whole collaborative, and especially our best practices committee. So thank you so much, and stay safe, everybody. If you have offline stuff you want to give me feedback on, we make sure you have my contact information. Love to engage in any conversation with any of you if that would be helpful. So thanks so much.
Yeah. Joe, thank you too. Thanks, everyone.
Thank you so much for joining. The recording will be on our website, and everybody is going to get added to our mailing list if they haven't already. So just let me know if you don't want to hear from us. And you can email me and I can help connect you with Joe as well. So thank you everybody for joining.